Welcome to our webinar on Emerging Therapies in Parkinson's Disease 2025. My name is Dr. Soania Mathur. I'm a family physician and someone who was diagnosed with PD over 26 years ago. I'm privileged to serve on the board of directors for the Davis-Finney Foundation, and I also have the pleasure of being your moderator today. So as we know, neurological disorders are the world's leading cause of disability, and of those illnesses, Parkinson's disease is the fastest growing. It is estimated that Parkinson's affects 11.8 million people worldwide and continues to be a disabling condition and, unfortunately, currently remains incurable. We don't have any medications yet that can modify the progression of the disease, and we still remain dependent on symptom treatment in order to try and optimize our quality of life. Thankfully, the research that goes into those treatments and disease modification continues to move forward, and we're going to talk about some of those emerging therapies today. To help us navigate what's new in this area is the one and only Dr. Michael Okun. Dr. Okun is a movement disorder specialist and is currently chair of neurology professor and executive director of the Norman Fixel Institute for Neurological Diseases at the University of Florida Health College of Medicine and medical advisor for the Parkinson's Foundation. He is an author of several books. I'm sure you've read some of them, if not all, including a new one that he has co-authored with Dr. Ray Dorsey, The Parkinson's Plan, A New Path to Prevention and Treatment, which is coming out in August, but it's available to pre-order today. Go to their website, pdplan.org, for more information. And I've had the privilege of getting a sneak peek, and it is such an interesting and informative book, gives you so many actionable directives that you can implement in your own life, and it's really an absolute must read. In fact, Michael, I don't think I've had the chance to congratulate you on another truly insightful book, so congratulations.
Oh, thank you so much, Sonia. It's an absolute pleasure to be here. You know that I feel like we're brother and sister. We've been doing this for 4 years. I've known you for even longer than that, and it is just so much fun for you to rapid fire ask me about these things, and so much fun for us to try to create an impact for people in Parkinson. And thanks for the call out on the book. All the proceeds to the book go to charity, as always, and Dr. Ray Dorsey is the co-author of the book, The Parkinson Plan, which is the new path to prevention and treatment. So yeah, it's a lot of fun, and we just love getting the word out and educating and helping folks to live better lives, and also to tell you about what's new and what's coming.
No, they're remarkable. It's such a pleasure to get. It's such a feeling of empowerment when you learn about action things that you can do for your own life and take action based on what you read. I really commend you for that. Your book puts forward a framework called PLAN: Prevent, Learn, Action, and Navigate. So I'm actually going to take direction from your book and look at the navigate part of the plan, which is navigating promising new treatments. So I'd like to direct our conversation into the 3 frontiers you write about. That's very Star Trek-esque, actually. I think you also liken something to the tricorder in your book as well. But so I'd like to take our conversation into those 3 frontiers. The first frontier, which are treatments that you can use pretty much now and in the next 5 years, so either newly available or close to market, treatments that alleviate symptoms in the near term. This may include repurposed drugs, electrical stimulation, pumps, etc. And the first drug I wanted to ask you about was Crexont. It's a new levodopa drug. Could you tell me a little bit more about that?
Yeah, no, and first, just a word to the Davis-Finney Foundation. Thank you for hosting this again. This is always one of those things that people love to replay, and they gave me this free hat several years ago, so I always like to wear my hat, because it's always fun to wear a hat like this in a place that's so hot like Florida, where you don't need a hat, but hopefully things will stay nice and cool during our talk and not get too hot. So let's talk first about Crexont, and first off, let me just say, do you know, Sonia, how these drugs get named, like how they get their names and things like that?
No, I would be interested in knowing, actually.
Yeah, so it's kind of interesting and a bit frustrating, I think, for folks out there, and even frustrating for me, because there's so many different names for these drugs. But the way that it works is that you have to consider the science, what went into, a drug, like why it, exists.
Right.
what was the mechanism? What's the regulatory? How is it regulated? And then how is it going to be branded, out there so people
Mm.
can find it? Now, all drugs are going to start out with some sort of chemical name. There's going to be some, like Dr. Evil person in the laboratory that's going to invent or publish or patent and many of these things go back into, the 1800s and many of the compounds that are used today, some of those early compounds. And so everything gets a chemical name. That's where it starts.
Right.
Chemical, you just describe the chemical, right?
Right.
And then there's the generic name. And so then a name pops up, and that name is usually awarded by usually it's the United States or the World Health Organization, and it's done by drug class or by mechanism, and it can be, also, by the company or the country that it's developed in. So I'm in the US, you're in Canada, and
Mm.
and so there's some sort of combination, and then there's something behind the scenes that kind of leads to that drug name. And then
Mhm.
the third thing is the brand name. Okay, so there's a chemical, right? There's the generic name by the mechanism. Then there's the brand name. The brand name is made usually by the company, okay, or by pharma, and it's made to be memorable and to hopefully represent what that drug is. And so when we think of, those three things, and we think of, oh my gosh, it's like hard to, keep all these things,
Yeah.
keep track of all these things, and sometimes they have numbers, early on,
Right.
the trials
Right.
and everything. It becomes complicated. And so as you and I talk today for people about all these new things, we overwhelm you with these names. We're also overwhelmed. I think. Do I speak for you, Sonia, too? Are you also overwhelmed by all these names and numbers and everything?
Yeah. Yeah. Particularly when in different countries they can have different names
Yeah.
as well
Yeah.
sometimes.
So let's talk. You asked about Crexont. So let's jump
Yeah.
right in. Crexont is a new formulation of a drug, and many people may have known this drug before the IPX brands of drugs that were extended release. Crexont is the newest, from the company. It's an extended release formulation, and it actually lasts a little bit longer than Ritari, okay, which came before it, and then immediate release levodopa. And the way that it works, Sonia, is this. It's kind of the pill is kind of divided into two sections, okay? One
Okay.
section has these immediate release granules, right? So you
Yeah.
want to get some drug in you right away. And the
Right.
other section of the pill has these extended release pellets, okay? And the pellets actually have what's called mucoadhesive polymers.
Oh.
Okay, that's a mouthful, right? But fundamentally what it is they're chemicals. Okay, polymers are chemicals that are put together to allow it to stick around longer and then hopefully increase on time, which is what the phase 3 study showed it did, decrease off time, and it actually showed it improve sleep. But guess what? If you improve on time, okay, and you decrease off time, a lot of times you are going to improve sleep. And so if we measure that, that is what we see. Now, there were about an hour and a half of good on time shown for each dose, like when people dose these things. And it turns out that you are going to get just a little bit more on time than you would with regular release carbidopa levodopa. You have to
Okay.
consider cost, okay? Never want to
Right.
send somebody out there if something's working just fine. Do you need something new? Not necessarily. If need to make sure you're not going to have them put a mortgage out on their house, for the benefit that this, drug gives. And sometimes you want to work your way to some of the newer drugs, but it does on paper give you a little bit more on time with your Parkinson. So that's kind of nice.
Michael, you might have just said this and I might have missed it, but was that an hour and a half more on time compared to Cinemat, or was it compared to like Cinemat CR and Ritari?
No, so it's about an hour and a half per dose. Okay, so when they
Okay.
calculated it in their formulation and what they showed in their study, and it's sort of like about 30 minutes more than a regular release dopamine kind of on
Okay.
average, just a little bit
Okay.
longer that it goes on. So, and what's interesting, Sonia, is people try to dig in and read about these papers and Crexont and everything, is they
Yeah.
show the data in so many different ways, which is so awesome, but also can be so confusing, right? Because then you're like, oh,
Right.
which direction am I looking at this? So it's just
Right.
a little bit better. It lasts a little bit longer.
Yeah, I agree. You have to kind of take it into the context of your own life, whether that on time is, worth it to you based compared to, starting something new and the price and that sort of thing. I can completely see that. The next when I was gonna, hopefully, I'm really interested in talking to you about this because it's a therapy that we can access in Canada and have been able to do so, and I believe it's also in the US, is Vyalev. And that's a different way of getting the levodopa into our bodies. Can you tell me a little bit more about how it works and what the advantages are
Yeah,
or any
so
potential issues?
no, and you know what's super interesting, Sonia, is that it has taken so long for us to figure out how to get dopamine across the skin. And you would think like, oh, like we're so super smart, like we can solve this problem. My entire career now into its third decade, and I got this hat on so you can't see my gray hair. It's the reason I'm wearing the Davis Finney hat. My entire career, we've been trying to get dopamine across the skin. Okay, and it's been really difficult. And there are these things called methyl esters, and there's chemical reasons why this has been hard to do. Guess
Why is
what?
it better, sorry, Michael, why is it better to get it across the skin? Why have
Well,
we
if you
been trying so hard to do that?
Yeah, so if you can get it across the skin, then you could get to continuous delivery. So you don't have to take all these pills. So you don't have that pill burden of like, I mean, that's one of the things that is just absolutely killing people. Not killing them, but you know what I mean. It's
Mhm.
not that pleasant to be on these handfuls of pills. And some people with Parkinson, they take all their pills from their entire day. Okay. And people listening, some people are going to say, yes, I've felt this. Hold out your two hands, okay, just like
Yeah,
this. Put all the pills in there and they won't fit in two hands an entire
yeah.
day's pill. So reducing the pill burden, has been, something that is super important. And so when we think about, phospholevodopa, phoscarbidopa, which is the first pump that was approved by the FDA, phospholevodopa is a pro-drug, okay? And it's a pro-drug, meaning when they say pro, that means it comes before, not that they're like professional basketball players or
Mm.
professional cyclists like Davis Finney. A pro-drug comes before, so it's pro-dopamine, pro-levodopa, and then it's converted to dopamine into the brain. Similarly, it's paired up with carbidopa, which is also a prodrug, phoscarbidopa. And what phoscarbidopa does is it blocks this peripheral conversion of levodopa to dopamine outside in your bloodstream so you don't get nausea, and it delivers to the brain where you need it to go. That's one of the magical miracles of Cinemet, which is carbidopa levodopa. But now you have these phos formulations. And what they did is they studied, there were a few studies on this, but to make a long story short, 141 patients, they had randomized controlled trials on this. They looked at troublesome dyskinesias, and guess what? About 2 hours, just under 2 hours, maybe a hair under 2 hours improved of on time per day. And the bottom line for that one, Sonia, is this: decrease your off time, again, improve your sleep, which oftentimes if you improve your on time, you're going to improve sleep. Most importantly, folks, decreasing your pill burden. And it's kind of like a diabetic pump. You get rid of the insulin and then you can not have to take these pills. Quality of life went up. You get this continuous delivery. And the issues with these pumps are that as they infuse, and you see this in diabetes too, you can get nodules, you can get inflammation. And so we tend to rotate these sites, around, and we look at the various, and different ways that we can do this. There's another pump that's kind of making its way through the FDA. It's kind of, gotten through some of the regulatory, but then there's got to be something for the packaging and manufacturing made by Neuroderm. And then there's a
Right.
pump, right? Isn't there another pump now, right? And it's for
Yeah.
dopamine agonists. Have you guys heard about that pump in Canada and around the new,
The Onapgo.
yeah, have you heard about that one?
Yeah, I mean, I don't know much about it. I know that it delivers, again, continuous infusion of medication, but it's apomorphine. Is
Yeah,
that,
so that's right. And it's important for people to know, right? Because here's another choice, right? It's
yeah. Is that
like,
available in the US now? Is it on the market? Can people
it is.
access it?
It is just FDA approved, so it's just kind of making its way right onto the market right now,
Okay.
and it's on the market in a couple of different areas, I think, in the world, and just sort of getting out there. But remember, apomorphine's been around a long time as a drug for Parkinson disease. How is it different than dopamine? Dopamine
Yeah.
goes in and replaces, right? It's like a replacement, and there are two parts to the nerve, okay, Sonia. And the first
Mhm.
part is the part where kind of all the chemicals come in, and they call that pre or before synaptic. And the synapse is that space between the two nerves, right? So you got
Right.
the synaptic and the dopamine goes here. And then you've got the chemicals go across like dopamine and they hit the other side of the nerve. And that's how there's transmission. And so when you read a paper and you hear about synapse, it's that space between.
Right.
Dopamine goes here. Okay, so that's one form of the pump, right? Dopamine agonists tickle the postsynaptic. It goes all the way across. It doesn't have to go across. It tickles on this side, the post,
Mhm.
the other side of the synapse. Okay.
Mhm.
So what's important is that it has a slightly different mechanism of action. And what we use these days is what are called non-ergoline or non-ergots. Ergots are things that can actually cause your heart valves to scar and your lungs to scar. So we're able to give these dopamine agonists. You have taken them orally before for different things, but a lot of those, like Mirapex, Pramipexole, all of those
Yeah.
things that we all know about, rotigotine patches, all of those things that we give orally are more on the D2, D3 receptors, okay? And so
Mhm.
what we're doing here is we're trying to give stimulation to the dopamine receptor, okay, postsynaptically, continuously. And when we do that, there was this study called Toledo, and
Right.
Toledo, which had Andy Lees and several other major investigators in Europe, showed us again, guess what? Right around phosphocarbidopa, phospholipidopa, right around that 2 hours, a little bit below 2 hours of increased on time without troublesome dyskinesias. And when you take apomorphine, Sonia, you have to worry about nausea. And so
Right.
oftentimes we give antiemetics for people who've had the ApoPens, right? Yeah,
Right.
so
Right.
ApoPens. And then for a while, there was apomorphine underneath the tongue,
Yeah.
sublingual. And if you stimulate too much, just like with carbidopa, phospholipidopa, you could get dyskinesia,
Right.
orthostatic hypotension. That dizziness when you stand up is a little more common with dopamine agonists. Can, of course, get sleepy, and people have reported things like headaches. But fundamentally, this is a therapy that is now going to be another choice, and it's going to take some time for us to sort out how how to choose which therapy. And many people will take a stop and try these therapies before moving on to DBS or focused ultrasound or other things like that.
Right. If it is like a dopamine agonist, is there an issue with impulse control disorder that they've seen with this Onapgo?
Yeah, so like the data we're going to have to wait for, but it doesn't look like we're seeing the same kinds of impulse control disorders we see with some of the D2, D3 stimulation that we see with oral carbidopa or oral dopamine agonists. But again, time will tell. I always like it when I think back, and too, because you're trained as a physician and a doctor, and when you're a medical student, they always tell you, yeah, it's a whole lot of fun to read the studies. And then as they come out and things come on the market, then you'll find out what they really do and what the side effects really are. And so before
Right.
we jump, to that, we think it's going to be much less.
And just one other question about pumps since we're here is the Neuroderm one that you mentioned that's coming out. How is that going to be different from Vyalev?
So it's very similar. The Neuroderm pump, there's some slight differences with how it's dosed, slight differences in how much you can take, and in the Neuroderm pump, there's a limit to the amount of dopamine they can give, and the formulation of dopamine is different than the phoscarbidopa, phospholipidopa, and so you'll
Okay.
still have to take medications at night with that pump. But it had very similar effectiveness. If you look at it again, just a hair under 2 hours a day, total effectiveness.
Okay, great. And this, since we're on the topic of equipment as opposed to pills, I wanted to ask you about adaptive DBS because that's part of the first frontier of treatments. It's available. Now, most of our listeners are probably familiar with deep brain stimulation. It's used to treat motor symptoms of Parkinson's. But what is adaptive deep brain stimulation and how does it work?
Yeah, so a number of us, and you probably know I'm a little bit biased because my lab has worked on signals in the brain for many years, but the whole dream for our lab and for many other labs, not just ours around the world, has been, hey, could we figure out a way to eavesdrop on the brain? And my wife says I'm a really good eavesdropper, okay? And so that's what I do for a living. And it turns out that we can. And the way that we can do this is classically we would put electrodes down into the brain and we would listen to the brain. And we were able to use this to design, therapies based on, okay, this signal that we're seeing seems to be lining up with this symptom that you're having,
Mhm.
slowness, stiffness, tremor. That's the basic idea. And so now as things have gotten smarter, and sleeker, for Parkinson,
Mhm.
we're now able to use the regular DBS leads that we're implanting and try to listen off of those, like we've been doing in the laboratory for many years, and actually teach the device in a very smart way to be able to pick up that signal. What is that signal? What's going on with you at the time? And deploy the stimulation at the time that it sees the specific symptom. And so what we're seeing now is an FDA approval on a device made by Medtronic in Minneapolis, Minnesota, where they are using what's called the beta band, and that's where things oscillate. And what they're looking at is that this abnormal oscillation occurs in the setting of Parkinson's disease, right around the beta. And so that's about, you know,
Mm.
13 hertz, 15 hertz, maybe up to 30 hertz, and that's how many times something cycles per second. And there's there's slower and faster beta. And we use those things to try to drive. Okay. So we're trying to drive a potential signal that we can use to, listen in when we see those bands called oscillations, use them to respond. And there's another band called the gamma band that actually gets, when you get better and your symptoms get better, the gamma changes, it goes up, and that's way up in the high several hundred hertz. And we can use that band too. And so we're just at the beginning, just at genesis of telling the devices and teaching them how to turn on and off automatically. Okay. Now, this might reduce side effects for some people. This may improve the efficiency of the device and certainly could improve the battery life. But does everybody need adaptive stimulation? Probably not. Do we know who should get it yet? Nope. Again, it's kind of
Okay.
these new drugs that come out on the market, right? And then it's gonna take us a little time to kind of work our way through. One of the most important messages that I can deliver today is that if you have walking, talking, and thinking problems, flipping on the adaptive and doing adaptive DBS, in most circumstances and almost all circumstances, it's not going to be effective, for those things. But it might be able to, like a sculptor takes a little bit, it helps sculpt that face and makes the eyes a little better, the smile a little better. It might be able to shave off a little bit of the slurring of speech. It might help you to help with a little bit of the limp, help you to be on a little bit more. And so there might be some benefits, but I don't want people to get into what's called the cycle of inflated expectations, where all of a sudden we're
Mm.
going to use this as a way to treat symptoms that haven't been responsive to DBS before. But it's super exciting. It's opening a
Yeah.
new frontier in Parkinson, and my lab works on Tourette. Okay, so we have a
Right.
NIH grant, multiple NIH grants doing this for Tourette for multiple decades now, and it's being done here in our labs and in others on things like dystonia and tremor. And so it's an exciting time, but that's the story with adaptive DBS. And if you decide you want to try adaptive, be patient, folks. You're going to go in. This is not a walk in the park. It's not like a set it and forget it thing. It's actually quite tricky. You have to find the signal. Not everybody has a signal. You have to find the signal. You have to have the right battery on the device. And then you're going to have to be working for potentially hours and hours and hours with clinicians to sort this
Right.
and to figure out, is it better, worse, same for you? We think it's going to help some people. So it's exciting, and we love having it in the armamentarium. And of course, being someone that's been researcher on it, I have to tell the group here, I'm obviously a little bit biased, but I don't want to oversell the therapy, and I want people to be kind of prepared if they end up going in to be seen.
Yeah, no, I agree. It's very exciting, but I'm just wondering, once you figure out who would benefit from it the most and obviously direct it towards that group, if you haven't already have a DBS system in place, can that be modified to an adaptive DBS?
It could potentially, but you have to have what's called the Percept battery, what has been FDA approved to do that. You just can't do that on any of the batteries and any
Uh-huh.
of the manufacturers. So the battery that's approved by the FDA right now is called the
Mhm.
Medtronic Percept battery. That's the
Mhm.
battery you would have to be placed in order to do this. Okay. And so that
Mhm.
would be the therapy that you would seek. Now, what's very interesting is the field has moved a lot in the past few decades, and one of the ways it's moved is being allowed to have leads from one company and potentially batteries from other companies. And our
Okay.
group hasn't yet, tried to deploy adaptive DBS on somebody else's, lead that has one of the Percept batteries. But folks, we're going to see this soon, right? Again, it's just come out. It's just you're going to start to see that coming. And I also tell people, don't always rush in. It's here now, right? And so there's an old saying that we like to use in our lab. It's cliche, Sonia, but it's the first mouse often gets to the cheese and gets the cheese, but also gets snapped in the trap, right? So sometimes if you go too soon, you get snapped in the trap, and you might want to wait a little bit, let some things get a little bit of experience. We're going to slowly work this out, and then we'll really know how to do it. But if you go and you feel like, oh my gosh, that my doctors don't know what they're doing, and my healthcare practitioners and advanced practice providers don't know what they're doing, guess what? Secret, we don't know what we're doing yet, in the clinic. So we're still learning how to deploy it in the clinic setting.
Sage advice indeed. Also along the lines of sort of technical interventions is focused ultrasound, that technique that uses high intensity sound waves to target lesions in the brain. What's the update on focused ultrasound? Like, what are the benefits and side effects, complications, that sort of thing?
So focused ultrasound is really cool. It's a therapy that's actually been around, believe it or not, for many decades. It was first used in neurosurgery in the late 1950s, actually, to make lesions in the brain. And the idea is pretty simple. We use sound waves. We go from outside the brain. We don't have to make an incision, okay, in the skin and drill a hole, through the skull, and we're able to access deep into the brain. Now, if your skull is too thick, which happens they say somewhere around 1 in 10, people have too thick of a skull. My wife is convinced I have too thick of a skull.
I was going to say the same for me.
Yeah. So I've been told that before, but actually there's a way to look at this, and so not everybody is eligible for it, but the majority of people are eligible. And the idea is, as you come from outside the brain, you use sound waves, and the sound waves are going to be used, to push deep into the brain and to create a lesion in the brain. And so this is an irreversible lesion. So even though there's no scalpel, they say no scalpel and no invasiveness that way, you're still making a lesion in the brain. It's not quite as exact as if we make a hole and we map it out with physiology. We listen to the cells. Remember the eavesdropping conversation. It's not quite as accurate as eavesdropping, but it's getting better and better. Okay. The testing of it in the OR isn't quite as accurate as the testing of, let's say, a DBS lead or a conventional lesion where we push down a probe, like a straw into the brain, and we burn a lesion. But if you get the lesion in the right place, a well-placed lesion has great, short and long-term benefits. It is getting better in the thalamus for tremors, intentional tremors. The thalamus is not the best target for Parkinson's disease because you have also stiffness and slowness, which you don't get as much in that area of the brain called the thalamus. There's a study in the New England Journal where they did it on pallidum, which is GPI. And although it was a positive study, it wasn't compared to other things. And if you talk to the experts in the field, it really wasn't as overall effective as they would have wanted it to be. You have to be careful of the optic tract, and it's the shape and direction of where those fields are coming from. And so that's not refined as well. And then perhaps the most exciting work is coming out of multiple groups in Spain and Toronto and in Virginia and other places. So I don't mean to leave anybody out here, where they're actually trying to make lesions in that tiny area, about 150 cubic millimeters, or smaller as it atrophies over time, that area we call the subthalamic nucleus. The biggest things that people are worried about is putting lesions on two sides of the brain, which may cause, talking and emotion and cognitive effects. Although it's not known why, but so far it seems that surgeons are able to put a smaller lesion in that second lesion, and they're getting less of those side effects than we saw in the last era of lesioning. So right now we stick to mostly unilateral. There have been some bilateral done. Most people that are being done with essential tremor. Some folks are getting it with Parkinson. It works well in the thalamus if you have an intention tremor, not a resting tremor. Okay, but intention when you're going stuff. It works better in the thalamus for that. And then they're working on the GPI, the pallidum, and then there's some exciting work coming out about the subthalamic nucleus. And you have to talk to your healthcare team, risks and benefits. What's better for you? Are you willing to give up a little bit of the accuracy, you know, to not have the actual surgery. Do you want to have a hole in the brain, or do you want to be able to modulate it with things like adaptive and other ADBS devices? Do you want to play sports? Are you on a blood thinner? We got to go through all these things. And that's why it's not, you know, this is not for amateurs. No offense. Don't do this in your garage, Sonia. I know that you're smart. But really important to have a team behind you to make all
Yeah,
these.
no, there's so much to consider. Very,
And there's
very true.
no right answer, Sonia. Like people say, oh, is it DBS or is it whatever? It's totally different for
Yeah.
everybody. Should you get
Well,
one side? Should you get two sides? Should you get it? What target? Should you get focused
yeah.
ultrasound? Should you get a pump? Should be a continuous shared decision making, you know, as you're going through these therapies.
Much like the disease itself presents so differently in people, the treatment is obviously going to also be determined by the individual themselves for sure.
Yeah,
So
absolutely.
also in Frontier One, just to switch gears, is repurposed drugs. And repurposed drugs are actually, I find, a really interesting field of research that's taking drugs that are used on the market for other disease states, but because their mode of action are tried as treatments for unrelated diseases, or they observe and unexpectedly have other effects. Viagra is a great example, originally developed as a BP medication, blood pressure medication, but obviously found to be great for erectile dysfunction. And Ambroxol is a medication, I think, that's commonly used to treat coughs and sore throats, but has shown promise and is being investigated as a potential treatment for Parkinson's disease. So my question is, how does Ambroxol, which is used to treat respiratory issues, potentially work to treat Parkinson's?
Yeah, so I love this question, love this therapy, love the story about it. Do I know whether it works or not? No, but I kind of love the whole story. So thanks for asking about it. You know, it is this cough syrup, you know, that has been available in Europe and other countries, you know, even over the counter in some countries, not available in the United States. I don't know if it's available over the counter in Canada. I don't think it is. But you can get this in Europe. And here's the idea. So you remember when you went to, do you ever go to a school dance before, Sonia? Did you ever do
I
that
have.
before? You
I
have.
have.
Okay. So when you go to a school dance, sometimes you have to have a chaperone, right? Somebody who
Yeah.
goes there to be watching you know, like along the way, or a parent. So these are called, you know, Ambroxol is what's called a pharmacological chaperone. It's something that goes along and it kind of watches and accompanies things along the way. And the idea of this drug is it goes after an enzyme, okay, in the brain called glucocerebrosidase. Glucocerebrosidase, okay? It's a mouthful. So that's why people call it GCase. Because if I keep saying it over and over again, I'm going to sound like I'm drunk, okay? Now, it's important to the features of the cells and of the brain for throwing things away. And there is a piece of the cell, not to get too complicated, called the lysosome. And how we throw away proteins that we don't want, how we chaperone them, how we traffic them, super important. What does Ambroxol do? It increases GCase, okay, that enzyme, that mouthful enzyme, increases the clearance of alpha-synuclein, which is what's in the Lewy body, which is what's accumulating, okay? And the question is maybe it'll slow down, okay, the Parkinson disease. It certainly crosses the blood-brain barrier, and we know that it's contained, it's one of these elements that's contained in cough syrups, often contained with other sedatives and things. And so be careful, you know, just going out to grab Ambroxol. And where are people using Ambroxol, Sonia? Well, if it works on GCase, why are they so interested in it? Tony Shapira and colleagues at UCL in London have studied this a lot. Great paper in JAMA Neurology. Several other groups have looked at this. Recently, a Canadian group as well. And if you look at this, GBA1, okay, the Gaucher's gene, if you have a GBA1 Parkinson, which is very common, guess what? That affects GCase, okay? And so if we can increase your GCase levels, the question is could we improve this in GBA1 carriers? We know it gets across that barrier called the blood-brain barrier, okay? And there's a trial that's going on now in the Cure Parkinson Trust, a big, you know, like trial with multiple foundation partners to try to sort this out, okay? And they're enrolling, guess what? You know, for everybody, alert, they're enrolling right now, and they're enrolling people not only with GBA, but they're asking the question, if you don't have GBA Parkinson, could increasing GCase help? Because some of these pathways might be similar. So we're going to get results here, you know, hopefully, you know, in the next year or two. So maybe next time I get to put my hat on and we get to talk, we'll have some results. But that's the idea. Don't run out and get cough syrup, folks. We don't know, whether or not it works. Talk to your healthcare providers. Okay, if you're within the confines close to where an ongoing study is, and you can find those on clinicaltrials.gov to see where Ambroxol studies are going in. I encourage you to consider enrolling. If you do decide to try to use it off label, okay, which I don't recommend, but if you do decide to do it with your healthcare providers, because a lot of these formulations, Sonia, that you can get from India, from Europe, and other things can be contaminated. They cannot be completely normal in their bioequivalence, and they can be mixed with different sedatives and things like that. And so you always have to kind of make sure if you do something to be as safe as possible.
Yeah. Not to mention they can interact with other medications you may be taking as well, which is important to know before you take something like that.
But I'm excited to see what happens. Are you excited about that trial?
I am actually. I'm excited about the other repurposing drug I was wondering about are something that everyone has heard probably way too much about, and that's the GLP-1 agonists like Wegovy or Ozempic, which were initially, I guess, formulated to treat type 2 diabetes and aid in weight loss, but claimed success for a number of different medical issues. And they seem to, they've investigated exenatide, I guess, belongs to this class, as well as lixisenatide is being studied as well. So can you tell me a little bit about how this may relate to Parkinson's disease treatments?
Yeah, and it's so great to talk to you about it, Sonia, because you're a family doctor, so you know more about this drug than I do, okay? But here's what I know. Just like you said, type 2 diabetes, this has been kind of a revolution in treatment for people with obesity and has provided substantial decreases in people's disability and increases in quality of life outside of Parkinson. And so it's had a huge impact, and we don't know short and long term how yet to use these drugs and so forth, but it's come up in a whole bunch of different areas, including Parkinson's. And it turns out that people are trying this. If you look at these classes of drugs, Sonia, you'll find them they're trying them for all sorts of things. It's like throw them up against the wall and see what sticks, okay? But I will tell you, okay, so that's fine. And that sounds like a criticism. But in Parkinson's, there's actually a reason to be trying it in Parkinson's. Why? It likes to go to the black substance of the brain called the substantia nigra, okay? When you look at GLP-1 receptors and substantia nigra, and in an area called the striatum, the putamen. And those of you that like to read about all these areas of the brain, these are two super important areas of the brain for Parkinson. They go to the mitochondria, which are like the muscle of each of the cells, and they're really important in metabolism and in oxidative stress. And we know that GLP-1s decrease inflammation. In animal models, they seem to decrease the protein clumps, the synuclein, the Lewy body clumps, okay? And what's really interesting, Sonia, and you might find this interesting as a general practitioner, a family practitioner, is that you could tell me they actually improve insulin signaling, but not just in the body, in the brain, which I find really interesting. So it could be good, from that perspective. And growing cells, in animal models called neurogenesis. And then remember those synapses, the pre and the post dopamine here, the dopamine agonists here, the synapse, that space. There's plasticity of how those spaces grow over time. And when you give GLP-1s, there's some evidence that improves. Here's the bottom line. First, there was several small studies of exenatide, which is one of this class of medications, okay? And those early studies showed some promise, okay? And then in the New England Journal of Medicine, just here recently, a few months back, we saw this lixisenatide. And I'm glad you said it first because I wasn't sure how to pronounce it. But the lixisenatide, which is no longer available on the market, was available in France. They did this study looking at motor progression, and it very slightly decreased motor progression. And it also improved some motor function. It didn't improve the clinically significant. There's a certain number of points you have to get to. But it was really interesting. And so we were all going, huh. And this was a 12-month study, a 1-year study. It was relatively small, but it had a reasonable number of patients in it. And it set off this revolution where everybody's like, oh my gosh, time for the GLP-1s, right? And so all of my folks that I take care of here, we have seen, we just crested 20,000 people that have been seen here at the Fixel at the University of Florida. Everybody's like, oh, GLP-1s, right? It's time to get going. And then, not so fast, as Lee Corso says on Sports Center, the exenatide, study at 48 weeks, okay, a 48 study, so almost a year as well, was negative, and that was published in the Lancet. So now you have one study of this one drug in the New England Journal, right? And it says, yeah, there's some signal here, and maybe we're at the beginning, we're nibbling at something, but we got to be careful. Now you got another study here, Sonia, that says completely negative in a similar class drug, but there are some differences between these two drugs. And so we're kind of left with, what do you do?
Right.
Well, here's the thing you have to worry about with these drugs. The reason not to rush in is that you lose muscle mass. And I've had a number of folks that I take care of who have rushed in to get these drugs. And so you lose some muscle mass, and that's not good because you have a continuous weight loss with Parkinson, slow weight loss. That's why you should be getting bone scans. That's why you should be trying to build your muscle. And that's why, for those of you who like to stay perfectly fit, always stay a few pounds heavier than your ideal body weight with Parkinson rather than a few pounds lighter. I know people don't like that, but I'm giving you permission to be a few pounds heavier. That's better for Parkinson, and losing muscle mass is not so good. And so you need to be on a monitoring program if you do it. Some people are doing it at lower dosages. We don't recommend actually that you do it, but if you have a hemoglobin A1C kind of in that borderline zone, and you're a general family doc, right? So between 5 and 6, and you're going to get on one of these drugs, maybe you can get some benefit with Parkinson, and maybe the dosages need to be a little bit lower. We don't know. We're a little bit confused in the field. We're not recommending it right now, but if you do decide to do it, make sure you're doing it with some sort of monitoring program, and you're watching your muscle mass, and also watching nausea and GI absorption, which is really important here, and nutrition. And so we've had a number of people get on and get off. We've had people go from higher dosages to lower dosages. We're just kind of watching what people are doing. And a lot of people that are diabetic are switching to this drug. Not a bad idea, but we need to get you on a weight program if you do it. And so that's kind of the GLP-1 story right now. So it's not over, but it's just gotten a little more either interesting or confusing, Sonia, depending on which perspective you take.
I think it's interesting for sure. I should have probably asked this question before, but it just came to mind is you were talking about the G case when we were talking about Ambroxol. And that kind of brings up that kind of treatment of genetic sort of variants, right? Like we know that 10 to 15% of people with Parkinson's have a familial history, which suggests a genetic or hereditary link, and several genes like the LRRK2, PARK2, PARK7, PINK1, so on and so forth, and GBA have been identified. And first of all, can you remind us why it's important to spend time looking for treatments that work on such a small subset of the PD community, and how does that benefit the entire community?
Yeah, so the Parkinson's Foundation, in full disclosure, I've been the medical director and the now medical advisor for Parkinson's since 2006. They have a study called PD Gene. Michael J. Fox has a study where they collect genes. There's GP2. There's all of these great genetic studies all over the globe that are combining all of their information. And there's a push to try to get people genotyped, or at least to meet with genetics counselors and to consider finding out your genotype means what do your genes look like. If you find out what your genes look like, then we can also begin to understand whether some of these therapies are working for some of these particular genes, but not others. Specific subtypes of the Parkinson, okay, might be important. And you'll have the option to enroll. You may not have known before if you didn't know your genotype to enroll in trials and then to get genetics counseling. But if you find out you have one of these genes, I will tell you, be really careful. Get a genetics counselor. We have 2 at the University of Florida, Lee Kugelman and Kayla Lashinger. They're amazing. And one of the reasons it is important to talk to a genetics counselor is, folks, here's a secret, okay? These are not completely penetrant. So when Mendel described genetics and he was crossing P's, everything was completely penetrant, meaning what you predicted is what you got.
Right.
80% of the time, if you have a GBA1 mutation, it doesn't manifest and cause Parkinson's disease. 90%, even if you have the mutation, it's only 10% penetrant, okay?
Right.
30% for LRRK2. And so, like, if your kids decide they want to get tested too, then you got to be a little bit careful, right? Because do they want to live with knowing they may or may not get something if this
Mm,
gene may or may not manifest? Having
fair.
said that, I think it's becoming more and more important for people to be aware that they have the option. Okay, remember, they're in charge. Okay, we're not in charge. We're like cabinet advisors. Like, I'm a cabinet advisor as a clinician. That's how I always sell myself. Just a cabinet advisor, never get mad at you, no matter what you do. If you want to try a GLP-1, whatever, I'm here to help you to stay safe, give you the best advice that I can.
Sure.
Okay. So when you think about this, as a cabinet advisor, I always tell people, if you know what your gene status is, you might qualify for one of these studies. And there are several of these studies. Like one, for example, was the BIB 122 study
Okay.
by Biogen. This is the LRRK2 drug, and Biogen and Denali, were the ones who developed this. And LRRK2 seems to be an important, enzyme, both to genetic and to other forms of Parkinson, and mutations of this LRRK2 gene, which is a very common mutation in Parkinson. They actually make things hyperactive, and they disrupt the disposal system. That thing in your sink, you're throwing stuff away, your
Yeah.
disposal system, again, called the lysosome. I don't mean to keep throwing that word out. And then the traffic. Okay, we talked about chaperones, but there's all this traffic of chemicals and things going across different cells. It disrupts the traffic, and then the whole system becomes inflamed, and we call that neuroinflammation. And so there was this small molecule that Biogen and Denali developed. It blocks down LRRK2, and the idea is to try to restore the LRRK2 kind of function, and to get closer back to normal. And they have a few studies that have been looking at this. There was one called the Beacon that was just a double blind looking at safety and how it worked and whether it got to its target. They had one called the Luma study that was for early Parkinson disease patients, okay? And they're still trying to recruit. These are really hard to recruit for. So, if you have, LRRK2, you should consider, the studies. And then it was so hard to recruit, they had a study called Lighthouse that just had patients with LRRK2. Their Luma study has LRRK2 and patients that don't have LRRK2. They stopped the one just with LRRK2. It's just very hard to maintain that study population. But again, here, back to your main question, okay? Not to subvert and get away from your question. Your question is, why do you wouldn't know about that unless you had your genetic status. And so when you watch TV and you see these cancer drugs, Sonia, and they say, take this cancer drug if you have
Yeah.
this receptor type of lung cancer, or type of stomach cancer, or whatever, fill in the Mad Lib blank. We're getting there for Parkinson, and then hopefully some of these things will pop and start to work.
Right. So I'm looking at the time. We've been chatting for a little while now. I want to move on to Frontier 2. So the 6 to 10 years in the future. And these treatments not only treat symptoms, but aim for disease modification and include things like stem cell replacement. And stem cell replacement, I think, is of real interest to our community. Sometimes we see it in a nefarious way where they're being promoted as a cure, but what is the latest approach? I know there's a lot of research going into stem cell replacement. What is the latest approach to therapy?
Yeah. And, great question. And guess what? This week, 2 papers in that awesome journal called Nature, one of our top, journals, 2 papers drop, just this week. And everybody is back on the line because there's been such disappointment in stem cells. It was like the great hope several,
Yeah.
decades ago. And then it hasn't kind of made it through, and we use it to screen for drugs. And now people have been working on, can they make a better stem cell? Can they make sure the stem cell gets in the brain, goes where they want it to go, okay? And also doesn't cause an immune reaction and improves the symptoms. And so we saw 2 papers out. One paper was from Sawamoto and colleagues. It was a Japanese paper. This was a induced pluripotent adult stem cell. So it's an adult cell, and if it's autologous, it comes from you, and we remake it and put it back into you. We don't need those immune drugs. It was only 7 patients, Sonia, so let's not get too excited. But it was safe, and it didn't have those extra movements, the extra dyskinesias, the runaway dyskinesias we saw on the big transplantation study. So very early days, on that one. And then same time, press release, bam, another one drops in Nature. This one by Tabar and colleagues. This is human embryonic stem cells. So the embryonic stem cells off the shelf, 12 patients, 5 got low dose, 7 got high dose. This one, because it's human embryonic stem cells, needed some immunosuppression, showed safety. And again, a little bit of a signal too for improving symptoms. A small number of folks didn't see the runaway dyskinesias, and so we'll await larger trials. And we're reminding people, I sent out a tweet, so if anybody wants to talk about this on any of the social media channels, it's really easy. At Michael Okun, we talk about all the great, debates and dialogues, but we want to keep people safe. If anybody asks you for stem cells for cash, I'll give you stem cells for cash. There are thousands of these operations all over the world. We do have a free 1-800 number at the Parkinson Foundation, 1-800-4PD-INFO, that can help you make sure that even on clinicaltrials.gov, some of these that are not legitimate are going to pop up even on clinicaltrials.gov, and we can help you, okay? And ask for two things. That's it, Sonia, two things. The research protocol that's institutional review board approved at an approved place that does research, and the consent form, and take it from the team that's asking you for cash. They should never ask you for cash for research, by the way, right?
Right.
They're asking you to do this. It's elective. Don't be in a rush. Bring it back to your doctors, your whole healthcare team, all the healthcare professionals, and do some shared decision making and just try to stay safe. It is super exciting with these two new papers, but still a long way to go.
Yeah, that's really important to be safe for sure. And it's great that you offer that service. Vaccines.
Yeah, so vaccines, here's the quick and dirty on vaccines. Again, you want to try to use the immune system, okay? And you take the immune system and you want to try to give a vaccine to elicit an immune response. Get your immune system to respond to it. All of the 3 vaccines that are kind of out there that are being trialed by 3 different companies are all targeting that Lewy body, the alpha-synuclein. They're all have shown mostly safety, okay, and tolerability, and whether or not it has a response, an appropriate antibody response. One is called AC Immune, okay, that's the company 7104. They've done a phase 2 with safety and tolerability. Vaccinity, UB312. Again, I told you there's all these names, right, across there. Again, stimulating antibodies. They've done a phase 1 safety and tolerability. And the third one is Afris, which also induces antibodies versus synuclein, the Lewy body. They've completed a phase 1 safety. So more to come, on that. And the question is whether or not, when we affect the immune system, it's later in the process when those clumps are already there. Is it too late? And we talk about this in the book, The Parkinson Plan. Ray and I talk about this. Do we need to look upstream? Do we need to, the cause and progression, and ask why we get Parkinson? That's the L, by the way. I know we're talking about the N today. The L is we need to learn why, and we need to be investing in that. The P is prevent, by the way. So, so that's where we are with the 3 vaccines in case people are interested.
That's great to know. And so finally, we get to the frontier 3, or the long-term therapies, 10 plus years down the road, where we think about regeneration, rebooting circuits, gene editing, nanomedicine. So what about gene therapy?
Yes.
The latest.
Yeah, so the latest on gene therapy is that, there are a couple of these gene therapy trials to keep an eye on, and there's actually been a few more, that if you look in the literature that are already done. But the AskBio trial, the AB1005 trial, everybody's asking about it. Nice name, right? And it's adeno-associated virus. That's like you get colds and stuff, and these are adenoviruses, can cause various things. And we use that as a vector or a delivery system to deliver a growth factor called GDNF, glial-derived neurotrophic factor. It goes into that important part of the brain called the putamen. And we're looking to increase survival, and we're looking to see whether or not this can regenerate and improve the fluctuations in Parkinson's and the motor symptoms. There's been 11 patients so far, seems to be safe, early days, and it'll be interesting to see how that one goes. Another one folks might be interested in, another great name. I don't, like I said, this naming, they're good at naming things. The Prevail gene trial. This is for GBA1. This is for the Gaucher's. If you have that gene, remember it's GCase, right? I'm not going to try to say the whole enzyme, okay? I'll sound drunk, okay? And they're using adeno-associated virus type 9, so a slightly different virus. And they inject it into a part of the brain that has a lot of fluid called the cisterna magna, hoping it's going to go to the right areas, restore GCase, and also improve the throwaway system in the brain. That's the lysosomes. There is another study called the Propel study that's ongoing for safety and tolerability, and we're just waiting for some results on that. But those two are two that we're looking at. When it comes to gene editing, okay, super exciting. We talk a lot about this in the book. And gene editing and nanomedicine, two super exciting areas. We got to get it right if we're going to edit things. We have to know when things in biologic systems in the body, if they make too much of something, not enough of something, then we choose gene therapy or we choose gene editing. And we cannot make a mistake with gene editing, okay? And
Right,
so
of course.
we're super good in the lab, but it turns out even in the lab, some of these things are still making mistakes. And so we're going to see this coming, okay, in the frontier, but we have to have zero tolerance for making mistakes when we're editing, people's genomes. Nanomedicine, important to go small, Sonia. The reason you go small is you can get it across the blood-brain barrier, and when you have the surface area to volume ratio and little teeny tiny, nano things, we can do all sorts of cool stuff. And guess what? We can bring the focused ultrasound and the ultrasound back in, and we can activate. And then I love this word because we're so uncool as neurologists, but now we're talking about uncaging. Okay, I love that. Like uncage, like what we uncage, so we can send things into the brain and we can uncage them. And so we talk about this in the PD plan about how we can uncage with putting thermal currents, electricity, thermal currents, ultrasound, genes together, and then we can combine up and do combinations of therapies like we've done for HIV, cancer, and polio and other things we talked about in our last book in ending Parkinson disease. Need to learn from these other areas as we're developing and navigating the new frontier, which is the end, essentially.
Wow, it's a lot of information. I think we need 90 minutes next year so we can cover everything.
We need 90 minutes, and we need them to send each of us a case of Red Bull so we can be chugging Red Bull. So here, we're just cooking.
So I'd like to thank you all so kindly for joining us today. I hope you found the discussion helpful and educational. I know I always learn so much from these discussions. So thank you so kindly, Dr. Okun, for your time and expertise. And remember, everyone, we may not have a choice in our diagnosis, but how we face the challenges this disease brings into our lives is ours to define. So choose to optimize your quality of life, educate yourself, empower yourself, and celebrate your daily victories. Until next time, be well and be safe.
Thank you so much for having me. And here's the information, folks, on the book here and the QR code. All the proceeds are to charity, as all of our books. And so this one is ready for pre-order. So if y'all want to grab it, there's a shameful promotion of the book, but all proceeds to charity. And we need to get as many people for the A, which we didn't talk about. The A in plan stands for amplifying our voices. And so if we're going to be as successful as HIV, cancer, polio, and these other things, we're going to have to raise our game with the PD Avengers, with all the Davis Finney folks, with everybody. We're going to all have to come together and push the disease. But so much fun, and we covered so much ground, and thank you so much for having me.
Thank you.